So if we find a patient has a liquid lock or type 3 movement or a disc block subluxation, which is all the same thing, and that is, again, leaning to one side and having a disc shifted there already and not allowing us to lean there, as we see here, what will happen over a period of time, and this is something that you want to explain to your patients because you've got to get them to comply to your recommendations, and they need to know what's really going to happen to them if they don't. And if they don't, this is what's going to happen to them, and it's going to happen pretty much every time. If you have a disc that is shifted over and locked, that spine will wear funny throughout the lifetime of that patient. And what happens is you have big bone spurs that start to grow. Look at the bone spurs here. All because this spine could not lean to that side because that disc is locked over. This person is only 54 years old, probably had a liquid lock since he was a kid. And over a period of time, that spine has buckled and it has not been able to have movement. And again, if we don't get movement in the spine, we do not get hydration. The discs dry out and they become like, like the heel of a shoe, dead old shoe leather. And if they have this problem now, while they're young and the spine is not deteriorated, now is the time to get in there, separate those joints, mobilize them, and get that movement back in the spine. That a lot of people do have a nice curve in their lower back. And that's not really the reason why we want the person to be on the rocker, the patients to be on the rocker. A lot of times, many of the discs will be in the right position, and they'll have a pretty good arc. There may be one, though, that's buckled forward, and that's the one that we want to get with the rocker. However, more important in the low back seems to be the problem we talked about earlier about the disrelationship between the sacrum and the fifth lumbar. So we have 3 positions that we put the rocker in. And position number 1 addresses this problem. Position 1 is mainly used for the problem we talked about earlier, where the sacrum has rocked forward or anterior, and or the fifth lumbar has dropped back. What we're trying to do here is we're trying to push the sacrum, the apex of the sacrum up, so that it goes up at the apex, down here, and the fifth lumbar is lifted up. We inflate the lower air cell first, the upper air cell second. And if you do this and you take a lateral lumbar, you'll notice that you will approximate those 2 joints. And it really is remarkable the relief that you can get using this. And that's position 1. Position 2 is the most commonly used position for the Model 2000. And this position really decompresses the joints a little bit higher in the lumbar spine. And it works on that problem we talked about earlier, described as a liquid lock or type 3 movement. Another way to describe it is a disc block subluxation. We want to have one air cell pull one direction, one air cell pull the other, and that's what this machine does. And it will lift, and it will separate, and it will hydrate those discs. What happens here is we're inflating the lower air cell, pulling the spine this direction in the lower portion, then inflating the upper air cell, pulling the spine that direction. We're separating the joints. We are getting disc hydration. We are getting joint separation. Position number 2, very important for the person with the liquid lock. Position number 3 goes high up into the upper lumbars and the lower thoracics, and we do have some doctors who are actually working down even higher into the thoracic region, and they find that they get a lot of relief for the patient by working on the thoracolumbar junction. Again, we're lifting that junction up and we're separating those joints using the air cells. Again, on all 3 of these positions, we recommend highly that you inflate the lower air cell first and the upper air cell second, and have the patient gently rock on the unit to help get some movement into that joint as the discs are being decompressed. As part of the 2006 IRB approved study that Dr. Sheely performed, here's an example of what happens when we use the Model 2000 in position 2 in the lumbar spine. Here's an individual who has kind of a buckle in the upper lumbar, lower thoracic spine. Still a nice curve. And again, you will see on many patients, they'll appear to have a nice curve in their spine, but they'll still have problems. And we mentioned the liquid lock and the disrelationship between the sacrum and the fifth lumbar. So even though there's a curve in the spine, we still can do some great work by decompressing the joints. The lumbar unit was applied to this patient while in the MRI, while on the Posture Pump Model 2000, and he was able to achieve 20% disc hydration or disc height improvement. Here, 21% here between L1 and T12, 25% here between L1 and L2, and 15% between 2 and 3. Now, the unit is being placed here in position 2, almost up into position 3. Obviously, as we work the machine down lower and lower or higher and higher, we get joint separation at various areas. And we've seen here that we've been able to take a slight buckle in that spine, and we were able to restore the normal shape to the lower spine, which, by the way, is an ellipse, if you'll notice, not a round curve like in the cervical spine. So you look at that, it's a beautiful ellipse. And when you use the dual air cell machine, the 2000, this is the kind of change you can make in the lumbar spine. I'd like to address some other questions that are good questions that have been submitted by various doctors and clinicians throughout the United States and now internationally. And one of the key questions that many doctors have had is, how can I implement this decompression equipment, the posture pump, utilizing the EED technology within my practice? And one of the recommendations that we've had from many doctors is to keep one of the units, whether it's the neck unit or the back unit or the full spine unit, in your room. And when the patient comes in who is being treated for problems with the spine, you want to show them how to use it when they first come in, teach them all about it, as we've shown earlier, and let them be able to put that unit on them while they're waiting for you to enter the room. That way you can hydrate the disc, you can shape the spine will be warmed up when you go to make your corrections or what other treatment that you have. So again, we like to have you keep one in each room and let them use it, let them warm up on it. And of course then when you send them home with the unit so we can get the long-lasting corrections we're trying to get, they'll already know how to use it, and you can see that they're using it, make sure they're using it right. And it's of course important to train your staff, teach them how to use it, let them know the proper way to get in, on and off the unit. And another question people have had was, should I make a correction if I'm going to make if I'm going to use diathermy, ultrasound, or if I'm a chiropractic doctor, I'm going to make an adjustment? Should I do that before or after they use the posture pump? We've had doctors recommend it both ways, and I think personally that if you warm them up with the unit before, it's going to make it easier to do the treatment, but you can just as easily use it afterwards, especially after you make a correction. You want them to use the unit. You want them to decompress the joints after a correction's been made. That's why it's so important that they have one of these machines at home. Another question that we've been asked is, how long should a patient use it in the office before you send him home with it? Well, as soon as they know how to use it. Right away, the sooner the better, as you can see from the MRI studies. The sooner the better you can pull those bulging discs back towards the nucleus and shape that spine, the better. Why wait? You want to get them on it as soon as that they're comfortable using it. Can you use it more than once in one day was another question. Of course. A lot of people, for example, golfers, they will use the machine before they go out on the golf course. They'll keep it in their locker, and especially the rocker, they'll rock on it in their low back, move it all the way up into position 3 and work on their thoracics. When they get done golfing, they'll go ahead and do it before they go home. They'll loosen up the joints again, decompress their spine before they go home. So that's important to be able to use it more than once sometimes. Of course, right before bed, the neck unit has for years been used by people. They say it relaxes them, helps them sleep better. And I think that if it's uncomfortable for your patient at first, you need to work with them a little bit on it, because we know they need to have their spine decompressed. We know we need to hydrate those discs and drive those bulges back to the nucleus propulsus and away from the spinal cord. So you need to work with them a little bit. You need to let them know you have a problem in many cases, and it's going to take a little time. It's kind of like lifting weights. You may be sore for the first day or two using it, but it'll pass. And that's very important that you work with them on that and let them know this is going to be something that's going to make their correction and their treatment worthwhile in the long run. Very important. Also, we do have informational brochures and such that we can give you if you call our office, and you can keep it in your lobby and your dressing rooms or your treatment rooms, as a lot of doctors have told us that they do. Another thing that we have found is that a lot of doctors who are now using intermittent traction on the lower spine will use the cervical posture pump and have a person inflated on that while they're working on the low back with the traction, and that's perfectly fine, and they claim to get great results with that. Another question that people want to know is, when should I or should I re-x-ray a patient, or when should I re-x-ray a patient? Historically, most doctors have waited about 5 weeks before they do a re-examination, but you can see from our work, we do it immediately. The MRIs, we will put a patient on a cervical unit or a lumbar unit, and we will immediately do another MRI to make sure we're getting the hydration, make sure we had the unit positioned properly. But again, that's up to your personal preference. I want to mention about the chin strap, and I know there's going to be a segment on our website that's going to show you how to operate the equipment, but the chin strap is really an optional piece of equipment. And you can see here that we have a adjustment on the chin strap, if I can hold this here. And you can unsnap the chin strap and completely remove it, or you can unsnap it and move it down one notch and loosen it up so it's not pressuring the chin. The chin strap is not there to pull on the chin. It's there merely to support the head strap. So it's there basically to keep the head strap from moving around. It should never compress the jaw, ever. It's unnecessary. Another question people want to know is, how many up and down reps should we do? I think that if you pump the unit up and leave it pumped up for 10 seconds or so and let the air out, do that 5 or 10 times. You can really feel the warmth in the neck and the back when you do that, and that's a good warm-up. Pumping it up and down about 10 repetitions, and then pumping up and leaving it there and having the patient work up to 15 to 20 minutes. Now, they may only be able to go 2 or 3 minutes at the beginning. Their spine may be straight as a rod, and you may have to really have them work with it until they can eventually get to 15 minutes. Once they get there, that's when really you should re-x-ray them, because then you'll be able to see the big change as their spine has molded to the shape of the air cells. There are contraindications with all exercise equipment, and of course this type of equipment is no different. Of course, if patients have bolts and metal plates inserted in their spine, obviously we don't want to have them use the posture pump unless you've got okay from the surgeon, or you are the surgeon who performed the surgery and you feel that it's going to help. I think that again, common sense here is the rule. And I certainly would not use it with patients with a metal, bolted into their spine. If there are any other questions, you can contact our center, and we'll be glad to answer anything that you have that we may not have covered in this video. Thank you very much.